Merci d'être encore là ce soir.
Thank you very much for still being here. It's a pleasure to see that such an important topic, which involves French policies and the roles of health professionals, can attract such attention. We are
celle de concevoir que c'est à partir de la France qu'on fait beaucoup de choses, qu'on sait des choses de manière merveilleuse, mais souvent on n'écoute pas ce qui se passe à côté. Je trouve que les expériences qui ont été, en particulier celles de M.SHAH, qui ont été rapportées sont tout à fait extraordinaires. Le deuxième plaisir que j'ai à animer cette table ronde, c'est quand même que ça rétablit l'intégralité de la parité par rapport à toutes les tables rondes qui ont eu lieu jusqu'à présent.
especially since we only have ladies in this roundtable, which is good for gender equality. Now, let me introduce our panelists. M.SHAH, who just gave a presentation. Claudine ESPER, who is a health law specialist. Corinne, who is a founding partner of Calmédica. Cécile, who is a doctor and a medical director of iLumens. And then BRAMAUD du BOUCHERON, who's a nurse and works in the ASALEE network. And it's quite amazing because the experience, the accumulated experience of those ladies is going to be of great interest for maybe people from the Ministry of Health, and is going to provide solutions that could be implemented right away. For instance, the gentleman who presented OPIMS has solutions which could be rolled out in France. But if you want, the ministry to approve them, it's going to take between 14 months and 18 years, because the first vaccination record implemented in France was implemented 10 years ago. So we really welcome entrepreneurs and new ideas, but it's not always easy to roll out their ideas. Now, Ami, I have a question for you. Based on what you've presented, tell me what could be the 3 recommendations that you could give to health professionals in France in order to change the mindset, maybe, and have better quality care.
So the one, 3 things, yes? So I would ask that.
If you have more.
Oh, that's okay. I would ask, it's echoing, yes. I would ask that the ministry think about 3 issues, actually, and ask themselves, am I providing the right service? What product am I offering? Am I providing it in the right place? You know, where am I providing the service? Is it supposed to be? Is it best served in the facility, or is it somewhere else? And who is providing that service in the best way? So is it the optimal person for the specialist to be providing a certain type of care, or is it somebody else? And so just thinking about those 3 areas can help redesign the structure of the care that we're currently providing.
So you're telling us that the whole healthcare system, French healthcare system based on hospitals, should be challenged?
Not necessarily. I'm just saying what we've experienced. You know, one of the first reverse innovations we've seen in the United States was by Jack Geiger. Well, he took this model from developing countries of having community health centers. And so we brought that to New York. This was, you know, decades ago. And so that was the first area of, like, how do we bring health to the communities? Because, again, health happens there. We have a motto by one of our foundations in California. It's that help happens where you live, work, and play. And so if we're going to think about how to do that, if you want to, then yes, I would ask yourself. So maybe the French ministry would want to just question those things. I'm not asking them to turn it around, but
Thank you very much, Ami. J'ai envie de poser tout de suite maintenant la question.
Let me ask now a question to Claudine.
On a essayé de faire changer des choses parce qu'il y a des gens très intelligents qui pensent beaucoup sur en particulier ce qu'on appelle la délégation de tâches. Délégation de tâches, ça va avec transfert de compétences ou plutôt la personne à qui on délègue la tâche réclame le transfert de compétences et celle qui veut déléguer la tâche n'a absolument pas envie de lui donner la compétence pour ça. Donc, par rapport à tout ça, j'aimerais bien savoir comment le système régulateur et le système législatif
the law and the regulation system could adapt in order to allow for those links between those different health jobs. How could we create more links? Well, you're referring to a mechanism which now exists in our health system. It was implemented a number of years ago. So what we call transfers and transfer of tasks. What you need to know is that in our healthcare system, health professionals are, well, there is a regulation. You can only be a health professional if you have a certain degree and if you have gone a certain kind of training. And for a few years, we've changed this system a little bit. We've implemented what we call cooperation protocols, which lead to the transfer of tasks. Now, these protocols exist officially have been existing since 2009, but previously we've experienced an interesting period from 2002, well, 2002, 2009, and then 2009 to now. So from 2002, the Health Ministry, Jean-François Mattei, commissioned Professor Yvon Berland to work on health professions. Professor Berland issued a report saying that the health professions there weren't enough links between those different professions, and that professionals need to there had to be more links. So we started experimenting on certain professions and certain territories. We launched 5 experiments in 2002, but it was only based on medical tasks performed by nurses. There was an experiment, for instance, a nurse following patients with hepatitis. In 2006, we decided to open the tasks those nurses were performing. So we opened the protocol a little bit, and the HAS, the French health authority, was in charge of monitoring all this. Then there was the second phase with a law which integrated this mechanism in our healthcare system, integrated it in a much more extensive way because it was now possible on the whole territory and for all professions. And today we do have those cooperation protocols. Now, to describe those quickly, to describe the mechanism, it is based on a voluntary approach by professionals. They agree to come up with a cooperation protocol. The HAS has established modality and has monitored all this. So, voluntary approach. And professionals, of course, have to work with their own experience and knowledge. They come up with a protocol which describes new tasks for all practitioners. It can involve doctors, pharmacists, and all the caregivers. So all health professions. The regional health agency follows the the mechanism and consults with the HAS. The HAS gives the final green light. Then the protocol starts. If the HAS gives the green light, it starts officially. And more recently, in 2013, we implemented the funders committee with all health authorities of the country, and they are supposed to consider the business economic model that goes with this protocol, and they can authorize different funding system. So different type of financing can be authorized by this committee. Now, these protocols, if they have the green light of the local health agency and the HAS, can become permanent. So this is really an important development, and I end by saying that in 2016, the Touraine law, which is supposed to modernize our healthcare system, provided in the law that assistant caregivers could be included. So this is an official recognition of a practice. The decree is going on, and this would be applied to the profession of nurse. And if you have a look at the website of the HAS, you can see that 40 cooperation protocols are currently being implemented. Thank you very much. So since 2002, 40 protocols. If this could be, if we had a KPI, I don't know if this would be considered effective. Another article was voted this year and created something quite specific, possible funding for organizations that are a bit different from usual organizations. Can you tell us about this? Well, to keep it simple, procedures are quite heavy. It's a bit difficult, involves lots of paperwork, lots of red tape. So not many protocols indeed have been set up, but a few. What's interesting is this new funding possibility, which is no longer based on health stakeholders. The regional health agency is in charge of finding possible funding. And this is an interesting initiative which could make protocols more attractive in the coming month. One last question for you. We also work in organizations, and I would like to know how you, as a director of a patients organization, you consider these developments. So, I mean, the possibility of seeing practices evolve and professions evolve. Yes, well, I indeed work at the National League Against Cancer. So if you take the patient's point of view, even if those protocols are not completely successful, I think that it improves access to care. We talk about medical deserts. Well, that's an improvement. There is increased fluidity between caregivers and a more diversified care pathway. So I think that for patients, it is interesting. However, we have to underline something. Information provided to patients. And the law provides that this information should be provided. And a patient who is being offered such a protocol has to be informed, has to know that the funding, that the tasks will be slightly different. They have to know that the objective will be different, and they can accept or not, and they can ask to get back to a more traditional system. Now we have two protocols, interesting protocols. One is in the Ile-de-France region, and another one is at a cancer center. But from the patient's point of view, well, it is interesting.
Merci, Claudine.
Thank you, Claudine. I would now like to give the floor to Anne Boucheron. ASALEE,
c'est une nouvelle façon de prendre en charge.
New way
c'est
of
véritablement quelque chose pour moi
taking care of patients.
qui vient de l'expérience de l'innovation inversée.
I know reverse innovation, and I would like to hear about this protocol. And how do you become an ASALEE nurse rather than a nurse hired by the government? Well, I'm going to answer your second question first. It is a choice. It is a choice that follows maybe professional maturity. You want to have a different relation to your patients. You want to provide cares in a different way. So when you join ASALEE, usually those are your motivations. Then when you join the ASALEE protocol, well, because ASALEE is a cooperation protocol with 4 sides for 4 different types of patients: cardiovascular diseases, diabetes, cognitive disorders, or PPCO. So to join the protocol, you first have to find a doctor willing to work in this protocol. So it's really the nurse wanting to join a protocol and wanting to collaborate with a doctor. It is for primary care, and this collaboration is taking place at the doctor's office for the doctor's patients. So this is the background, and then you can become an employee of the ASALEE organization. The ASALEE organization is named after the protocol. The ASALEE protocol was part of the second experiment conducted in 2006 of task transfer, those BRAMAUD experiments. It was first the initiative of the Professor Gauthier. So it really started with a doctor making an assessment. He was working in a medical desert, and he thought, well, I don't have time to take care of certain patients with those problems. So it was difficult to follow these patients back then. So he decided to start working with other doctors. He got the support of the region he was working in, and he also got the support of engineers. So all of them managed to develop this ASALEE protocol. In 2004, the experiment started with 4 nurses, and now we have about 600 nurses collaborating under the ASALEE protocol, and 2,000 doctors. So this is for the context. Now, our practice, well, we receive patients who were identified. We conduct screening based on biomedical features in line with protocols. And we support them, we assist them, we help them. And this takes me back to the previous presentation. We really try to have a psychological and social support. That's very important because behavioral changes have to be taken into account. We have to accompany the patients, and when they have social problems that hamper treatment, well, we have to take that into account. I could go on for hours. Well, there's something that I find very interesting when we prepare the roundtable. 2 points that are at the basis of reverse innovation. You start with the needs of the patient, just much like we start from the ground when we work in a developing country. I practiced medicine in Gabon, and well, if you don't start from the ground, the system will not be sustainable. So this is what you do. And secondly, you have an approach which is completely modern. And I'm thinking about those living labs. Living labs, this is a cooperation between local organizations, local elected officials. And rather than implementing a solution which comes from above, from the top, they try to find adapted solutions on the ground in order to solve a given problem. So you were talking about, I think, sleep disorder. You conducted work. I would like you to tell us about this. You collected information and then trained your teams. That's really surprising. It's really interesting. Well, indeed, this is something which... Well, let me give you some background information. I told you that we were 600 nurses, and through these cooperation protocols, which are common to all of us, well, each of us still has a specific practice, and each nurse works with a specific doctor on a given territory, which is also different from other territories. I might get back to our organization, but we have freedom, and we can really give attention to the problems of the patient. So we can listen to the patient's needs, and we have the ability to act and respond depending on those needs. So rather than getting back to the sleep disorder, I've identified a number of innovations that I came up with, or my colleagues came up with. First, innovation in line with a community. I have a friend working in the Seine-Saint-Denis department, rather underprivileged department, and she is working with the Malian community. So your approach can be based on community. I'm thinking about colorectal cancer screening. This is something that she carried out in the Malian community, and she really took into account the culture of the target group. I have another example. It is a group of nurses in a very rural region of France, so completely different from the Seine-Saint-Denis department, very rural, very leafy area, but with doctors scattered all across the territory. And they've started working on the territory by creating links between doctors and by basing their activity on common work. And there is incredible energy on this territory. They've created healthcare centers, and this really started with the doctors' willingness. They created amazing things, groups of patients, healthcare gardens. They are really creative in this territory. And another friend works in another region, in Poitou. She was working on cigarette use. And she came up with a protocol in order to help patients quit smoking. So we now have a protocol. And nurses and doctors created a training mechanism, internal training mechanism. So now everyone is qualified, is trained, and can implement this protocol depending on the needs of the patients. So 3 examples of innovation. We have 600 other examples. I have one last question, which is a bit provocative. But since we're in a centralized country, I have to ask it. When you have a bottom-up approach like this one, how do decision makers react? They're located in Paris, so how do they, are they encouraging? Do they monitor the mechanisms?
There are 2 types of decision makers, I'd say. So you could imagine that some control us, but it would be very difficult. There are 600 of us nurses. The organization we have chosen definitely fosters autonomy and the collaboration between nurses and doctors. ASALEE went through various stages as it was being rolled out. And it has its own specific form of organization, but it keeps building up. So today I'm here, but any other one of the 599 other nurses could have been sitting here in my place, because we are all equally involved in the co-construction of the organization. We've all had the training. We all work to recruit as well. well. I work in R&D, in training. We each have our mission, so it depends on our competencies and what we feel we want to do. So then there are the doctors who devote time to this as well, and we have a whole team of engineers, and they are there to help us build the structure. So they are the interface between ASALEE and the rest of the world, financiers and all the decision makers out there. So they protect us to a certain extent, and the part they play in our system is really very important. We are supported by the team of engineers. It's a bit like a chocolate mousse. I don't know who's the egg, I don't know who's the chocolate, the doctors or the nurses, and never mind, but there's the egg white. The engineers are the egg white, and together we get this rather wonderful dynamic. So when you're talking about healthcare, when you talk about engineers in primary healthcare, I think it's already a bit of an intellectual revolution, a very welcome one. This leads me to Corinne SEGALEN. Calmédica is a system which is quite out of the ordinary, and I thought that I saw that you were using text messaging as well for your work in the field. Well, I'm a physician. I'm not an engineer, but when we set up Calmédica, I did this with my colleague who is an engineer and works in artificial intelligence. So we use robots which can dialogue with human beings. So this is a technology we've made available for a problem we felt hospitals were grappling with, that is the managing of outpatients. Hospitals are increasingly technological centers, so the hospitals need to manage all these outpatients, and it's quite complicated because they don't always have the necessary resources to do this. Let me give you an example. It's been developed. We've been present in quite a few hospitals, from the small country hospital to major Paris hospitals. I'm talking about outpatient surgery. So you know what that is. The patient comes in the morning and goes home at night after surgery. So these patients need to be monitored at home. And what we suggested was that our robot get into contact with them, and this goes through phone messaging. And so the robot communicates with the patient, sending out questions on the eve of the operation to check that all is going well, that they're feeling okay, and reminds the patient of the various things they have to bear in mind, that they shouldn't eat after a certain hour, etc. So this is very useful with patients that might be a problem. And if there's a problem identified by the robot, then a message is sent to the hospital. So it's a system which has a surveillance activity and can send an alert. So then the patient is asked if they're okay or what the problems might be. That is after the surgery, and the patient then answers the questions put by the robot, and the replies are processed. And if a problem is detected, a warning message is sent to the hospital. So it's a system which is based on algorithms. These algorithms are predefined, have been validated by the medical authority, and by that I don't mean me, but the client, that is the person in charge of outpatient surgery. and then the robot runs the algorithm. So, what's the acceptance rate? What do the patients say? Well, they quite like it. One of our clients, the Saint-Antoine Hospital in Paris, carried out a survey, contacted patients. Some patients were contacted by phone, others by text message. And then the question was put to those who had got a phone call, would you have preferred a text message? And conversely, those who'd got a text message were asked whether they'd have preferred a phone call. And it turned out that many more patients would prefer a text message over a phone call. And then the question was why? And the answer was that a phone call is often disruptive. You may be in the middle of an open space office, for instance, or you might be in the supermarket doing your shopping and you don't have a pen and paper to write things down. That's just life, isn't it? But if a text message comes in on the phone, patients can read the message when it suits them. So they rather prefer text messages. And I found that quite interesting because ZIP also made a study of resistance to new technologies amongst healthcare workers. And it turns out that patients are far more willing to embrace new technologies in this sense than the professionals. Now, we don't really have any experience in developing countries, but we have already some experience in more remote areas in France. For instance, areas where there is no 4G coverage. If you're talking about Burgundy, be careful, be very careful. Well, there is no 4G coverage in the Paris metro. There are places in Paris where there's not much of a telephone coverage. So people tend to resort to text messaging because a text message often comes through more easily, even if you're in a place where you can't really phone. For instance, on a train, on a high-speed train. But you can send a text message successfully, and patients are familiar with the medium. And text messages are aren't very often left unanswered. The response rate is around 95%, whereas the phone calls, when they ring the patients, they only get 60% replies. They leave messages, etc. But the text messages aren't very disruptive, and the response rate is as high as 95%. And it also helps us track what has been done. We know everything, and we can really trace back to everything that has been said and done. Well, thank you very much. If you're going to change mindsets and concepts, you need to change professionals as well. And to change doctors isn't an easy thing. So it's difficult because here we have members of the academy, and it's not an easy thing, and you have to change initial training in particular. Now, there's some problems here. There have been a few reports on the subject. There's a lot that needs to be done to change mindsets amongst young professionals. So what can you do with more modern technologies, techniques which are more disruptive, which aren't part of the traditional learning framework? Well, as they say in French, impossible isn't French. So anything is possible. We have a bit of a problem in France, but not only in France, which is that basically doctors are trained more or less the same way they were 100 years ago. And society is moving ahead as well. Now, I'm a bit of an odd bird because I knew early on that I wanted a double career, twofold career, medicine, yes, but also new technologies and finding ways to integrate them into medicine. And people would say to me, you're totally out of your mind if you don't want to spend 100% of your time devoting your efforts to medicine. It means you're not interested in the patients. I heard the most terrible things. And yet today there are a great number of new technologies which are available on the market. And only a few years ago, all those technologies stemmed from entrepreneurs. And they were usually young people, people who were in good health, who felt that medicine was an interesting area to develop something for, that money could be made whilst improving medicine. Now, I have quite a few examples, but for instance, the connected baby dummy, a dummy which can take the temperature, the child's temperature, but a dummy isn't a medical device, so the temperature reading is not reliable at all. So something was being sold which wasn't reliable at all. And putting an electric circuit in a child's mouth 24/7 didn't seem a very good idea either. And then you had health workers who worked in the community and had a lot of ideas as to how technology could be brought into medicine, but they didn't really have time, so it remained pie in the sky. And they didn't have the skills, the know-how in terms of business and marketing. So some, of course, did manage to achieve something, but more often than not, it fizzled out. There'd be a design which wasn't particularly pleasing, and the patients weren't asked what they thought. So when they received the device, whatever it was, whether they liked it or not. So unfortunately, it didn't always work out. And if you get everybody to work together, you're putting a lot more chances on your side. Now, it's not always easy. I do realize that. I know that in medical schools it's very difficult to change things, but students nowadays tend to do their learning at home with their books, with their computers. So there are things that should and can be done. Now, I work in a simulation laboratory, which is a university laboratory with several platforms in several Paris university sites. And what we do is probably reverse innovation. What we do is to help train health professionals. So we are going to be there between theory, the books, and the first time with a patient. For instance, when I learnt how to perform a lumbar puncture, I had to learn it from a book. There was a drawing and a short paragraph of explanation. And that's how we're supposed to know how to perform it. But when you perform this, you don't know what it feels like from the inside when the needle is inserted. And we all have these horror stories of times it didn't work out perfectly well. And when it was time for my first lumbar puncture, there were 5 of us to do this. And I don't really think that that is the best way to go about it. So what we're going to focus on is how to learn gentries. So we would have actual devices emulating patients' backs in order to practice on. And then we also have high-fidelity simulation, where we have humanoid played mannequins, for instance, a pregnant woman about to give birth, and the students can practice on these very high-tech devices. And we bring everybody together, not just the student, but also doctors and nurses. And I remember the first heart attack I witnessed. I didn't know the nurses. I didn't know where the equipment was. It was all rather complicated for me. So what we are suggesting we can do is to teach everybody to work together, how to communicate with the team, with the patient. And then another thing we do, we bring in actors who will be playing the role of patients, because there are a lot of communication issues between doctors and patients. It's important to know the patient's name. You have to know that you shouldn't stand there with your arms crossed. For instance, announcing that an 8th-month pregnant woman's baby has died in utero. And all these sort of things, we can simulate scans, and so using technology, but going well beyond that. Well, professors, you're going to have to adapt to all this. I think it's going to be quite interesting. I almost want to study all over again. So what about... Will doctors be taken over by robots? Will they have to become transgressive? They will become the patient's everyday ally and not just the expert in disease. Yes, indeed. Doctors will have to be playing a different role. And that is something we don't learn in medical school either. And this you see through the media. You look at the media, and what you're reading is doctors are all going to disappear. It's going to be medicine without doctors, and so on and so forth. But when you are a doctor and you are so busy that you don't have time to look at anything else, quite a few doctors tend to not really know how to go about this. It's because they don't have the information and they're getting hit in the face, so their attitude is to reject it all. So usually when you explain it to them, things go quite well. Patients will be coming in with all the data from connected devices, etc. And these doctors say, well, but I'll never have time to do this. I'd have to do it at 4 o'clock in the morning. So the part played by doctors is going to change, but doctors will not be replaced by robots, by machines. Because these devices will always have to be fed data, and you'll always need humans to feed the right data. So the technologies will help doctors for diagnostics in their choice of procedures and therapies. Now, this afternoon, we heard compassion, we heard empathy, we heard hope in the eyes of the patient, we heard the word love. So if machines can recognize these things in a patient, that's all very well, but a machine can't react to it, can't give a response. machines will not be showing true empathies. It will only be a semblance of empathy. So only a human will understand the whole picture. Machines will understand a symptom, but patients are a lot more than just a sum of symptoms. So the doctors will be able to choose how things are going to be explained, how they are going to be repeated. Together with the patient, they'll be able to select the best possible treatment. And the choice must be there. Some patients like dealing with a machine, but others don't feel comfortable with it at all, and you mustn't have to force them. I'd say that there's still a long way to go, and doctors are here to stay for quite a while yet.
Ami, j'ai une question à vous poser.
Ami, I have a question for you. Isn't there something you could do together? Cécile, Corinne, and you, they would bring in a layer of technology, and you could bring in the human touch.
Yes, absolutely. Especially working in a community where it's so vast and there's often technological barriers, meaning like there isn't enough technology that would make things more efficient. We would love to have more technology brought to Los Angeles County. So yes, we have tried some different things. So some of the, again, this is a governmental challenge that we just face because of the structures. It's some of the personal information, what we call PIH, the personal health information that is confidentiality issues, there's privacy issues that, of course, the patient, and so we're just working through some of that already in terms of doing phone appointment reminders. But we did find that the CHWs wanted to text their patients, and their patients would want to text them. They would call at all hours, and so working through, again, some of the structural barriers around union, litigation, all of that is something we are starting to take on, but it has been something that we would love to do. So absolutely, yeah.
Merci beaucoup. Corinne, tu as un micro.
Thank you, Corinne. You have a microphone, and then we can move on to the audience. Well, you were talking about nurses, but I'd say it's exactly the same thing there, because robots will take over from nurses the types of work which isn't really nurses' work. For instance, calling patients to find out if they're doing okay. So our robot freed up time for the nurses, and heaven knows nurses are always short of time. And for instance, there can now be nurses' consultations for outpatients, explaining to them what is going to happen when they go into surgery, etc. And it all improves the quality of outpatient surgery. Patients feel more comfortable because they have people there who can answer their questions. Now, my colleague, who often says he's from the countryside, although his father was a doctor in Paris, you have to really adapt to who the patient is, every individual patient. Yes, because when there aren't enough doctors and there aren't enough nurses, it's a good idea to have that sort of tool. Well, yes, I think there are situations which are slightly different whether you're in a hospital or in primary care. I feel that technology is something that you're going to integrate. Of course, you're going to take it on board. You can't go against the trend. But for primary care purposes, so it's not elective, it's not surgery, we're not talking about hospitals. What people need is human contact, and support. I see this with my patients. Yes, they are quite happy to try new equipment, but I spend time with them on learning about choice. Why is this application useful for you? What do you think? So you really need the human support alongside technologies. For instance, connected scales is one thing, but we nurses are still sent out to go and see the patients. So these are all things which are very welcome. You have to remain open-minded, but you mustn't forget the human aspect of things. For us, it's clear that when you're talking particularly about the chronically ill, they really need the human side of this.